Welcome to anemia. Today our topic of interest is going to be dealing with anemias. So for the boards, obviously hematology is very high yield and anemias is a very big topic. So I want to give you my framework of a mind map that you can use to get your answers right for the boards. Okay. So first step, when we get a patient and we say anemia, we're going to look at hemoglobin. Okay. And your hemoglobin is going to be low. If the hemoglobin is low, you are going to call it anemia, right? So the moment on the clinical stem you see anemia and your hemoglobin is low, what should your mind automatically go to next? MCV. Okay, it's all going to go to MCV. Now when it goes to MCV, what is your normal MCV? Between 80 to 100. Okay, that's going to be normocytic. Okay, 80 to 100. Now if it is less than 80, we're going to call this microcytic. And if it is greater than 100, you're going to call it macrocytic. Okay? So today what I want to cover is going to be microcytic anemia. When it comes to microcytic anemia, right? So moment you get anemia, you say MCV and you look at the MCV, it's less than 80. Once you say it's less than 80, you call it microcytic. Once you say microcytic, what should be the causes you should think of? Iron deficiency anemia, which is going to be your number one, right? Iron deficiency anemia. Number two? Anemia of chronic disease, which is no longer called anemia of chronic disease. It is called anemia of inflammation, right? So anemia of inflammation. Okay. And then what is another cause? Thalassemia. Good. And what's another one? Fourth one is going to be sickle cell. Is actually going to give you more of a hemolytic anemia, which is going to be normocytic. There's only 4 causes. When it comes to microcytic, it's always only been 4 causes. What is the fourth one? So Sideroblastic anemia is going to be your fourth one. And these are 4 conditions that you really need to know very heavily about. If I had to pick out of these 4 conditions, the one that you must know the most is going to be iron deficiency anemia. Number 2 is going to be anemia of inflammation. Number 3 and 4, thalassemia sideroblastic is going to be probably lower yield, but I'm going to cover most of the points that you probably need for the boards, and that's all we're going to do, right? Okay, so when it comes to iron deficiency anemia, right? Now, let's go over the normal physiology of iron absorption so we make sense of what's going to happen, and then we can talk about the pathologies, right? So, when you eat iron, right, where do you normally absorb iron from? Huh? You're going to absorb iron from the duodenum, right? This is your duodenum, and this is where you're going to absorb iron from. So, what form do you typically eat your iron in? Fe3 plus is the form you're going to eat it in. So, when it comes to the gut, it's going to get converted to Fe2 plus. This physiology is probably one of the most physiologies that you need to know in hematology, because it'll make sense out of it when I get to the answers later on. Okay, so you convert Fe3 plus to Fe2 plus. Then how do you absorb this iron into the intestinal cell? Via a transporter, which is called, how many valence does this have?
5.
Bivalent or divalent, right? So divalent is iron and metal. It's metal, so divalent metal, and this is a transport, so it's a DMT. The name is very simple. Now once it comes in, iron has one of 2 fates. Okay, you can either store the iron within the cell, or you can push it out into the blood. So if you bind iron to apoferritin, you will store this as ferritin in your intestinal cell. Okay, or you will push this iron through a channel which is called, what is the channel called? Ferroportin. Channel called ferroportin into the blood. Okay. So channel called ferroportin into your blood vessel. Okay, this is blood vessel. Yes. So once the ferroportin, it pumps it out and you get iron outside of the blood, how does iron get transported in the blood? Via a transport protein called transferrin. Okay, it's going to be carried by a transport protein known as transferrin. Okay, got it? Now this same process that happens with intestinal iron absorption essentially happens also in macrophages as well as your bone marrow cells. It's the same process. So the question is the iron going to stay within the cell, or is it going to be pushed out into the blood? Is going to be your question, right? Okay, now that you understood this part, let's hold on to this thought. Okay, if somebody is iron deficient, right, let's talk about causes. Who gets iron deficient? Is it dietary deficiency? No, it's never dietary deficiency. There's plenty of iron in the food that we eat, that you don't really get deficiency of iron because of a dietary deficiency. Why? There's one word. Bleeding. Blood loss. The one word you should think about when it comes to iron deficiency needs to be bleeding. So when you think of iron deficiency, the one word you want to think about is bleeding, right? So if it's a female below the age of 50, we think of menstrual. Okay. What else can we think about? If a female, below the age of 50, what else can happen that could cause iron deficiency apart from menstrual bleeding?
Postpartum.
Still bleeding. So postpartum, we'll put that in too. Okay. What about partum by itself? Pregnancy, right? So pregnancy itself, you're not bleeding in pregnancy, right? You're not bleeding in pregnancy, but pregnancy have increased requirement, right? So pregnancy by itself becomes an important cause too. And then you also have lactation, okay? Also when you're lactating, you actually will have an increased requirement of iron, okay? What about men? What about men below the age of 50? What should you be thinking about? Is it below 50 normally? If you have family history, yes, you can think of colon cancer at a much younger age, but normally it's a much older age, right? So men most of the time is a GI blood loss, right? GI bleed, which could be peptic ulcer disease, gastritis, some form of GI blood loss is what you're going to think about, right? Now if it's males or females above the age of 50, what should you think about? Colon cancer. That becomes a prime suspect. Okay? Colon cancer becomes a prime suspect. So this is how you want to think about when you think about causes of iron deficiency. Now, is there anything else that can also cause iron deficiency? Malabsorption. Good. Because if somebody had malabsorption, okay, affecting which part of your gut? Your duodenum, right? If you have malabsorption affecting your duodenum, then it becomes a problem. So what malabsorption condition can affect your duodenum?
Celiac.
Huh?
Celiac.
Celiac disease, very good. So celiac disease, very good. What else? Another condition that can literally,
Lactose intolerance.
lactose intolerance is going to give you more of a diarrhea, but not really. Inflammatory bowel disease, which one can essentially affect anywhere from the mouth all the way to the rectum? Crohn's disease, right? So Crohn's can cause it too. Okay, what else can give you iron deficiency? Huh?
Plummer-Vinson syndrome.
Plummer-Vinson syndrome, yes, you can. Plummer-Vinson syndrome. This is basically when you have esophageal webbing that's present, so essentially dietary deficiency as well as malabsorption can happen. Yes. What else? Yes, if somebody's undergone a gastric bypass surgery, good. Gastric bypass surgery. Okay, what else? What about medications?
Anticoagulation.
Anticoagulation, if it led to bleeding, then end of the day it's bleeding, right? What about some medication? The reason I drew this H+, you secrete H+ from your stomach, right? Is the stomach acid required for iron absorption? Yes, it is. You actually need stomach acid to absorb your iron. So if you don't produce acid because you're on what drug? PPI. What about H2 blockers? Yes, antacids. Anything that can decrease your acid from your stomach would lead to an iron deficiency. Okay. Does old age lead to aclohydria? Yes, it does. So you can actually have age-related aclohydria. hydria. Okay, that could cause it too. What else can cause it? Could you have an infection here that can do it? I gave you a clue. H. pylori, right? H. pylori infection is actually associated with iron deficiency anemia. Okay? So that's another thing that's important to know. So this basically covers pretty much most of the causes that you need to know for iron deficiency. And if somebody is iron deficient, right, what symptoms are they going to present with?
Fatigue, weakness, cardiac,
Right.
shortness of breath.
Fatigue, weakness, shortness of breath, tachycardia, right? What is something that's going to happen very unique for iron deficiency if it is really bad? So thrombocytosis is something important in a lab perspective, right?
Pica.
Pica, right? You can end up with something called pica. So pica is basically when they eat stuff that they're not supposed to be eating, like chalk, or a lot of ice, or soil, right? So pica is something that can actually happen when you have very severe iron deficiency. Okay, now that we know the causes, I think everybody would identify symptoms pretty easy, but knowing these causes is important. I think the bleeding bit is pretty straightforward, people not remember. But this, gastric bypass, the PPI, H2 antacid, 8-clohydria, and the H. pylori, people might forget. So remember that as an important cause for iron deficiency. So say we suspect iron deficiency, right? What are we going to do? How are we going to prove your point? Because in life, you have to prove things objectively, right? Your subjective gut feeling has to be left at home. Yes, very good. So, if you're going to objectively prove it, what are you going to order? You're going to order an iron panel. So, what are the things we need in the iron panel? You're going to get a serum, iron. What else you want? Ferritin. Okay, good. Then you want to get transferrin, which is also called TIBC, which is total iron binding capacity. And last is going to be percentage saturation. Has this question been asked in every step exam, almost in every time the test is set? Yes, right? So let's not ever memorize it. Let's understand it and master it, okay? So when it comes to iron deficiency anemia, obviously, what would happen to your iron levels? Will be low. Good. What would happen to your ferritin? Will be low. What would happen to transferrin? So now this is the part of the story that I have not completed, right? So I said, when the iron comes into the blood, it binds to transferrin, right? Now, is there a relationship between transferrin and ferritin? Yes, there is. It is inversely proportional to ferritin, okay? Transferrin is a transfer protein that's produced by the liver. Its job is to bind iron and transport it around. It has an inverse relationship to ferritin. So if your ferritin goes down, what happens to transferrin? It goes up. That's it. Pretty straightforward. Okay, so in this case, since ferritin is going down, transferrin should go up. What about percentage saturation? How do you calculate that? It's iron divided by TIBC, right? So in this case, iron is going down and your TIBC is going up. So down divided by up, therefore it's going to be low, right? So that's how it's going to look like in a patient with iron deficiency anemia. Now, I have to bring another question here, which is going to be anemia of inflammation, because this is the close one that they're going to confuse everybody with. Okay? So when you talk about anemia of inflammation, what happens to your serum iron? Will be low. Very good. What happened to ferritin? High. Okay. Why? So let's continue back to our story again. I want to keep circling back to this story because slowly the story is getting built and it'll make more sense. Now I said the iron comes and gets absorbed into your intestinal cell via DMT transporter and then gets stored in the cell by binding to apoferritin and forming ferritin and then gets pushed out to the ferroportin channel into the blood as iron, right? Do you need to have a checkpoint on this channel? Do you need some form of something to give a negative feedback to this? Yes, because if not, what's going to happen? This channel is always going to be open. The channel is always open. You're always going to keep reabsorbing iron non-stop and go into iron overload. So what controls this channel? What is that? HFE actually codes for this protein. So what is this magical protein that controls your... No? Hepcidin. This is your magical word you need to remember. Hepcidin. Okay? Some say hepcidin. I like hepcidin. You can do as you choose. Okay? As long as we all get the same word. So hepcidin's job is to have a negative feedback on this channel. Right? Hepcidin is produced by the liver. What codes for hepcidin protein? HFE gene codes for this protein. So HFE gene is going to code for hepcidin. Hepcidin is going to come and inhibit this. So when you talk about anemia of inflammation, right? Who gets anemia of inflammation? Anybody who's in an inflammatory state. Any rheumatologic condition, diabetes, okay? Anytime anybody's in any form of inflammatory condition, you're producing a lot of inflammatory cytokines, and that inflammatory cytokines should be stimulating your liver to produce more hepcidin, okay? And that inflammatory cytokine is called interleukin 1 and interleukin 6, okay? So you produce interleukin 1 and interleukin 6, which stimulates your HFE gene and basically produce a lot of hepcidin. So if you produce a lot of hepcidin, what's going to happen? The hepcidin is going to now come and shut this channel off, right? If you shut this channel off, let's try this again. What happened to serum iron? Are you absorbing iron to the blood? No, so it's going to be low. But what's going to happen to ferritin? It's going to increase, because if it's not going this way, you're going to store it within your cell. So ferritin goes up. Makes perfect sense, right? Now if ferritin is up, you have an inverse relationship to transferrin. So what would happen to transferrin? It should go down, right? And then what should happen to your percentage saturation? They're both going down, so it could remain normal versus it can go down, okay? So that's a key difference. If you really had to pick from the two, the way you're going to differentiate both of them is between your iron and your ferritin. So really, your ferritin is going to be going in opposite directions here. But don't memorize it, understand. It's pretty straightforward once you know the story. Got it? Okay. So now that we've understood that part, how are we going to treat somebody with iron deficiency anemia? Huh? Well, you want to find out what the cause is, right? Most of the time people are going to be bleeding from someplace. So you try to treat the bleeding. But most of the time, you still have to supplement iron. Even if it's a GI bleed and you put somebody on treatment, if your iron is low, regardless, you have to put them on iron supplementation. So what is going to be your treatment? What would you pick? So you'll go with ferrous sulfate, which is PO, right? First off, its question is, would you go PO versus IV? Almost always you're going to go PO first. Unless there is a reason why you can't tolerate PO, then you can go IV, okay? Ferrous sulfate is the one that's been the oldest, but you have new ones such as fumarate and gluconate, okay? But anyways, as long as there's a ferrous before it, you know it's a iron supplementation, right? Now when you're going to give somebody iron, right? What are some philosophies you need to follow?
You could just do it every other day for better.
Okay, so say,
Like don't drink it with milk.
so do you want to give iron every day? Or do you want to give it twice a day? Why?
It's the same.
So you're saying if somebody is very badly iron deficient and you're on once a day dose, right? You don't want to go twice a day to increase the iron that you're giving? Why not?
Because it's
Does
having the
the
same.
absorption limited?
It does limit the absorption. You know why? Whenever you give too much oral iron, it actually increases your hepcidin level. It's all to do with hepcidin. Whenever you give too much oral iron, it actually stimulates increased release of hepcidin, and the hepcidin is going to shut off your channel. So never ever give twice a day. You can give every day, but what is preferred now is every other day. You want to give it every other day. Okay? Now what else can you give your patient to increase absorption? Vitamin C. Very good. So you want to give vitamin C with this. Do you want to give this patient with some antacids or PPIs? No. Why? Because we already know if there's no stomach acid, there is going to be a problem, right? So you don't want to do that, right? Okay. Now, say you give iron supplementation, okay? What is the first thing to change? Is it going to be a change in your reticulocyte count, or is it going to be a change in your hemoglobin? What is going to happen first once you start supplementing? Reticulocyte count is going to increase within how many?
1 week.
1 week? First few days. First few days, what would happen is your reticulocyte count would go up first. How long would it take for your hemoglobin to go up by 1 point if you start them on oral iron supplementation?
3 months.
1 week.
Oh my God.
1 week. Okay? Once you start people on oral iron supplementation, and if it's doing good, within a week you should have a rise by at least 1 hemoglobin point. Got it? I think that's the important point. They are going to ask this in the questions. Okay? Okay. Now, when you give people oral iron, obviously it's going to have side effects. What is one of the most common side effects of oral iron? Constipation, right? Everybody gets constipated with this, right? Constipation. Now, again, the reason we kind of went through this whole process is to understand a lot of problems could be affecting oral absorption. There's a lot of people with peptic ulcer disease, GERD, they're on antacids, they might have celiac disease that prevents you from using oral, right? And if you have no other choice, then what are you going to do? You will do IV. What is the biggest problem that you always worry about
Allergy.
giving?
Allergic reaction.
What kind of allergic reaction? Anaphylactic. Okay. So all this iron we do is IV iron dextran, right? The biggest problem that we've always worried about is anaphylaxis. But nowadays we have newer formulations that actually has lower allergicity, so you can actually do it. It doesn't happen that often as before. Okay, so IV iron you would give if somebody cannot tolerate PO. You don't have to know about everything else, just this amount, it should be enough. One other cause that we did not mention here for iron deficiency is what? Huh? Actually, you can put, one is pretty obvious. If somebody is a blood donator, right? Blood donation can drop your hemoglobin and your iron deficiency, right? What about people who are undergoing dialysis? What about people undergoing dialysis? We don't think about it. Everybody, every single time they go for dialysis, they lose a small amount of iron that is enough to cause iron deficiency anemia. So dialysis will also lead to iron deficiency anemia. Okay? I think if you knew all of this for iron deficiency, you're absolutely golden. Okay.
Also, how do we use the RDW? Because you know how they
Yes. Okay. Good question. So when it comes to iron deficiency, there is something unique that we call anisocytosis. What this means is you having varying size of RBC, and this happens because when you're iron deficient, you're not very effective at producing red blood cells, and as a result you'll have multiple different shapes and sizes of RBC. Okay, and as a result, whenever this happens, your RDW, okay, your red blood cell distribution width would appear as elevated. So your RDW here is going to be elevated. Now hold on to that thought, because I don't want to kill the suspense. I'm going to tell you when it would be different and when you would actually compare the RDW with the other condition to differentiate it. Okay. Alright, now when it comes to anemia of inflammation, since we have completed with iron deficiency anemia, anemia of inflammation, the straightforward question that's going to be coming for the boards is knowing what is the conditions that cause anemia of inflammation, anything chronic, including diabetes and anything that causes inflammation. Why? Too much interleukin 1 and 6 and know your iron panel. Okay. Now, how do you treat anemia of inflammation? But the iron is low, right? What do you give? Big question when it comes to anemia of inflammation. On a treatment standpoint, yes, you would treat underlying cause. Okay? Treat underlying cause. Big question is, if your iron is low, because it is supposed to be low, right? And your ferritin is high, would you give this patient iron supplementation? No. Answer is always no. Never ever give iron supplementation for somebody who's in anemia of inflammation. Why? You're overloading a patient who's already overloaded. So that's not what you want to be doing, right? So no iron supplementation. Okay, good. Now just to complete this story, when it comes to iron absorption, the key factor seems to be the hepcidin, right? The hepcidin being present at a high level is the one that's controlling and causing problems, right? Now we said it is coded for by HFE gene. So could you have a condition where you can become iron overloaded? Yeah, hemochromatosis, right? You can get hemochromatosis. Good. Now when it comes to hemochromatosis, right, you are expecting this gate to always be open. Why? Because you have a mutation in the HFE gene. So what's going to happen? You do not produce hepcidin. And if your hepcidin is not produced, this gate is always going to be open. So you'll always keep reabsorbing iron and depositing it everywhere, right? So when you get a patient who you suspect of iron overload, this is the exact opposite, which is hemochromatosis. Primary is going to be hemochromatosis. Secondary is people who get blood transfusions. Okay, that's it. So when it comes to primary hemochromatosis, just to kind of integrate this point here, what is your test of choice for screening? You're suspecting hemochromatosis, you'll get an iron panel, very good. You get an iron panel, what specifically in the iron panel are you going to screen with? Ferritin, very good. You're going to look for your ferritin. Now your ferritin is going to be high, right? If your ferritin is high, you're like, okay, this patient probably can have hemochromatosis. But so can somebody with anemia of chronic disease, right? Because it's an acute phase reactant. So ferritin is a reasonable test to begin with, but is that the best test? No. What is the next best test? No. Before you get to genetics, you need one more step. No. Percentage saturation. Okay? Because your ferritin can go up because you're in acute reactive phase. Okay? But your percentage saturation will need to change. In order for you to suspect hemochromatosis, your percentage saturation needs to be greater than what? More than or equal to 45. Okay? If your percentage saturation is greater than or equal to 45, now it falls into the picture of hemochromatosis. Once you have that, now what can you do to diagnose? Now you check for the HFE gene mutation. Okay? Okay. That's it. Okay, now we're going to go into thalassemia. Now the boards doesn't go after thalassemia so much, probably because we don't see it so much in the US. It's seen mostly in African Mediterranean population. Okay, the simple philosophy to understand, let's keep it as simple as possible so everybody gets it. We don't want to go too deep into it and not understand anything. So when it comes to thalassemia, first off, we'll talk about the types of hemoglobin that the human body has. What do all of us have predominantly? Adult hemoglobin, right? HbA. What is another type of hemoglobin that we all have? HbA2. Okay? And when you were a child, you're going to have HbF. So these are the three types of predominant hemoglobin that we all have, right? What is HbA made of? 2 alpha and 2 beta. Good. What about HbA2? 2 alpha and 2 delta. And what is HbF made of? 2 alpha and 2 gamma. Okay? That looks like infinity. 2 gamma. Okay? These are the three. So everybody's got commonality, which is alpha. Okay? But for adult hemoglobin, which we are the most concerned about, we need beta. So now we are going to cause some problems. Okay? Typically, when it comes to thalassemia, if you look at beta, you have 2 genes that code for it. Okay? Typically, you need 2 beta genes that code for it. So if you lack just 1 beta globin gene, okay, you'll end up with something called beta thalassemia minor. Okay? If you have both beta globin chains missing, which means you have 0 beta globin that you can make, so you cannot make adult hemoglobin, you'll get something known as beta thalassemia major. Okay? If you can't produce adult hemoglobin because you don't have beta globin chains at all, right? So you can produce HbA2 and HbF, which is not effective, right? So these patients are going to become transfusion dependent. So most of the people with HP thalassemia, beta thalassemia major, they will be transfusion dependent. Okay? Now when it comes to alpha, so here for beta is a story of 2. When it comes to alpha, how many genes do we need to code for this? 4. Okay? So you need 4 genes. So what if 1 gene is missing? Is that a problem? Not really, because you still have 3 genes, you're okay. What if 2 genes are missing? So this one, no problem, right?
2 genes trait.
2 genes missing, you're going to get alpha thalassemia trait, right? Good. Which is going to be like beta thalassemia minor, okay? It's going to be like beta thalassemia minor. Now what if you have 3 missing? You will have something known as HBH disease, okay? You will have HBH disease, which is like beta thalassemia major, which is going to be transfusion dependent, okay? Transfusion dependent. Now why do you get beta? So that is going to be beta thalassemia major HBH disease, okay? And you get this because you have 4 beta globin chains joining together. Okay, when 4 beta globin chains join together, you get HBH disease. What if you have 0? None of them are present. All 4 are missing. You get something known as hydrops fetalis. Hydrops fetalis. This baby cannot be born. You cannot live, right? Hydrops fetalis. And the hemoglobin you form here is joined by 4 gamma. 4 gamma joined together to form hydrops fetalis. Bart's hemoglobin is what you call it. Okay, hemoglobin Bart's. Bart's hemoglobin. Now, when it comes to thalassemics, okay, whenever you suspect a patient as hemoglobin be running low, right? You have a patient who is looking like he's got, fatigue, weight loss, and looking pale, and you get a blood count and your hemoglobin is low. Next thing you always do is MCV, we already said, right? What's going to happen to your MCV with thalassemia? It'll be low. In fact, it'll be very low. Okay? It'll be very low. It'll be like close to the range of 60. But still falls into the microcytic picture, but low in the 60s. Now, but if the microcytic, immediately our mind goes to iron deficiency anemia, right? You think of iron deficiency anemia, you think of all the other conditions, but thalassemia is part of it. Now, what can make a good difference if you got a peripheral blood smear, okay, in this patient, okay, versus if you got a peripheral blood smear in your iron deficiency anemia? What's going to be a key difference? In iron deficiency anemia, you'll have anisocytosis because it's not a genetic problem. It's a problem in production due to iron deficiency. Here, it's a genetic problem. So when you produce small cells, you produce small cells but uniformly. You will not change shape. So you will not have anisocytosis, and therefore your RDW should be normal. Got it? So that is your key difference with RDW. It's to compare thalassemia with iron deficiency anemia. Now, can they bring a thalassemic patient into this and ask you what your iron panel should look like? Yes, they'd like to do that. What would the iron panel look like in thalassemia? Is there a problem with iron? No, everything should be normal. Got it? Baseline, everything should be normal. But if we give too much iron,
Because of the transfusion.
because you're giving transfusion, if somebody is transfusion dependent, then you'll go into an iron overloaded state. That's the key difference. So on the stem, you pick is the patient under treatment versus not. If you're not under treatment, this should be normal, 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 normal. If you are giving transfusion, then your iron should be high, ferritin should be high, transferrin should be low, and what should happen to your percentage saturation? Both are high, so it's going to be high. Got it? That's the key difference. So they can give you a thalassemic patient with this iron panel as well. Got it? Wonderful. Alright, so when it comes to thalassemia, important thing is to be able to identify what the thalassemic patient is, okay? And the RDW becomes very significant here to compare with iron deficiency. Treatment is going to be blood transfusion. Yes? Okay. That's it. So the fourth condition when it comes to microcytic anemia is going to be sideroblastic anemia. Now the boards likes this, okay? USMLEs have always liked it, the ABIM boards also likes this. So when it comes to sideroblastic anemia, okay, what causes sideroblastic anemia?
Lead poisoning.
When's the last time you were exposed to lead?
When I was a child. When I was
Back in the day, house paints and stuff used to have lead in it, right? Nowadays, a lot of things are not lead exposure. So, let me ask the question a different way. When it comes to sideroblastic, why do we call it sideroblastic? You have ring sideroblasts. So you have a red blood cell which has mitochondria within it. Okay, you have mitochondria within it. This is mitochondria. And if you have a lot of iron deposited, if you had a lot of iron deposit, which is red, okay, iron deposited within this mitochondria, and you form this thing which looks like a ring, which is called a ring sideroblast, right? So that's what's happening, right? So moment you say sideroblastic anemia, from now on moving forward, I want you to say one word. What that word is going to be? Two words. Heme synthesis. Okay, let's think of it a little differently. When you say sideroblastic heme synthesis, just say it out loud. Okay? So now I'm going to take you to heme synthesis. Okay? I know everybody loves biochemistry. You don't have to know all the steps. I'm just going to pick out what we want. Okay? We need glycine plus succinyl-CoA in the presence of enzyme delta-ALA. You're going to form something known as delta-ALA. Okay? Then you go from delta-ALA by another enzyme known as delta-ALA dehydratase. This is delta-ALA synthase. So delta-ALA, then you from by the dehydratase enzyme, what you form is known as porphobilinogen. Okay? I do not care about the next steps that happen until we get to protoporphyrin. Got it? Protoporphyrin gets converted to heme if you add iron to it by the enzyme ferrochelatase. Okay, doesn't look that bad anymore, right? We picked out literally a few steps that we want. Okay, that's it. This is your heme synthesis pathway. Now, part of this process happens in the mitochondria of the RBC. Part of it happens in the cytoplasm. Okay, everybody understood that? Great. Now, one other question. Doesn't mature RBC have mitochondria? It does not. Immature RBCs, initially when they're born with mitochondria. As you mature, it loses the mitochondria. That's why when you look at a mature RBC, it only does anaerobic glycolysis. It relies on the 2 ATP that's produced with anaerobic glycolysis. You do not do aerobic glycolysis in a mature RBC, but immature RBC has mitochondria. Okay? Now, what is the cofactor that's required for this first step? Vitamin B6. Okay, now let me ask you this question again. What is the cause for sideroblastic anemia? Huh? B6 deficiency. Good. Who gets B6 deficiency?
Isoniazide.
Yes, isoniazide. Good. Again, are a lot of people on isoniazide right now? No, right?
Alcoholic.
But let's go trace back. Why does isoniazid cause B6 deficiency? It's in the name. The one drug company that's been honest with the public is isoniazid. You know why? They call it INH. Guess what N and H stand for? N is for neurotoxicity, H for hepatotoxicity. Right? So they've been real with us. So INH, it causes hepatotoxicity. if you have hepatotoxicity, you guys love ordering labs, right? What labs do you typically order to look to see if there's a problem with the liver? Huh? See, people, what specifically are you looking for? AST and ALT. Good. AST, ALT. You know what AST and ALT need to function? Vitamin B6. So if your AST and ALT goes up, are they working more? Yes. They're working more. Are they going to use up vitamin B6? Yes. If you become deficient here, would you get deficient here? Yes. So what would happen is this pathway is going to get affected and you will not form protoporphyrin. So what's going to happen? You're going to deposit all the iron into the mitochondria that's not going to be able to bind to protoporphyrin. So you're going to end up with something called a ringed sideroblast. So it makes sense, right? So anytime you cause a vitamin B6 deficiency, you will end up with a sideroblastic anemia. But I just wanted to make that point, but not a lot of people are on INH, right? But all of you like to drink something that can deplete your vitamin B6. What is that? Alcohol. Very good. So if you drink alcohol, what does it do? It actually destroys the liver. Your AST and ALT goes up, right? And as a result, B6 will get used up and you will end up with sideroblastic anemia. So if you think about one of the most common causes, it's actually going to be alcohol. So I'm going to put number 1 as alcohol. Number 2 is INH. And number 3 is lead poisoning, because it's not very common anymore, right? Now, alcohol and INH make sense, right? Even when you study for the board, you still want to understand. You don't have to memorize anything in medicine, right? So, alcohol and INH, we understood why. Why lead? Good old lead. Why does good old lead cause problems?
It inhibits the... one of the
Lead
enzymes.
is also called a denaturer. What does denaturer do? It denatures proteins. Are all enzymes proteins? Yes, it is. All enzymes are proteins. So lead, it actually denatures your delta allele dehydratase and your ferrochelatase. By taking out both the enzymes, you end up with sideroblastic anemia and ring sideroblast. Yes? Okay. Now when it comes to lead, it also causes some other problems. What are the other problems? A good mnemonic is LEAD. L for lead lines. You can get it on the gums as well as in the bones. Okay? E for
Excited, it's like psychosis.
erythrocyte basophilic stippling. What is that?
That's the blue dots in the circle.
So you get an RBC with a bunch of blue dots everywhere, right? What is that? This is known as an erythrocyte basophilic stippling, but why does it happen?
Is it like the remnants? Yeah.
So normally RBCs has RNA material floating around, okay? Don't think it's all clean in those RBCs. Random RNA material is floating around, right? And do you need to have a cleaner for this random RNA floating around?
Yeah.
Yes, what are we going to call it? RNA ribonuclease. Okay? RNA ribonuclease is the enzyme. And what does lead do? Denatures your RNA ribonuclease.
So it's not clear.
Therefore, it doesn't clear and you will deposit all this RNA material, and that's what we call erythrocyte basophilic stippling. Got it? Okay. A is for anemia, which we've already spoken about, right? And D is for drops. It can actually cause neurotoxicity, so you can have wrist drop and foot drop. Okay, wrist drop and foot drop. What nerve do you need to drop to get wrist drop? Radial nerve. Good. What nerve do you need to drop the foot drop? Huh? Common peroneal nerve. Good. How do you treat lead poisoning?
Give them
Chelation with?
EDTA or like the.
You can give
Depends on how high it is.
EDTA or dimercaprol.
Penicillamine? No, that's for copper.
EDTA or dimercaprol, and you can use Succimer in kids. Okay, Succimer in kids. Okay, but if you knew this much for lead poisoning, you should be good enough. It's going to be a question about knowing when to identify and how you're going to diagnose it by the presence of ring sideroblasts, and if it's lead poisoning, how you're going to treat it. Now, when you look at your iron panel in a patient with sideroblastic anemia, what would it look like? I'm going to draw this thing again. Iron, ferritin, TIBC, and percentage set, right? If it is sideroblastic anemia, okay, sideroblastic anemia, the way I want you to remember this, are you depositing a lot of iron in the cells?
Yes.
Right, so it kind of feels like an iron overload, right? If you're depositing a lot of iron in the cells, you have less iron in the blood. So you're going to start reabsorbing a lot of iron, right? So it would look like an iron overloaded situation. So what would happen to serum iron? Should increase, right? Because you're going to reabsorb a lot more too. What happens to ferritin? Should be up, TIBC should be low, percentage saturation should be. If iron is going up and TIBC is going down, what should happen? Should be going up, right? Okay. That's it. If you just worked your way through this process every single time, you should get the answer right. But the iron panel is going to be a question for iron deficiency, anemia of inflammation, thalassemia, and sideroblastic anemia. They will ask the same question for all 4 conditions.